My name is Gattinoni. I would like to speak about lactate in sepsis. And I think it's important to enlarge a little bit the field. There is not only lactate, but the transport SVO2 and so on. I will try to propose you a sort of not new, but quite a new model on how to afford the problem in sepsis. Let's say, okay, these are my conflict of interest. And then, let's see, in sepsis, what we have to provide? We have to provide an adequate tissue perfusion. And, if you take the guideline of sepsis, you see, whenever you have a sepsis, give 2 liters of fluids in a quite short time. Is that correct? I would like to call your attention on 2 variables, which are the venous saturation and the lactate. And for simplicity, we start with the venous saturation, and then we go more in depth with the lactate. So, what is the saturation? The venous saturation has a great variables, which is a sort of summary variable. We will speak after that about the mechanical power, which is another summary variables of many things, because when you have changes in venous saturation means that or the arterial saturation has some problem, that means the lung has some problem, or oxygen consumption or cardiac output, the ratio between the two has some problem, that means metabolism and hemodynamics times the transport. You have hemoglobin, which may have some problem. So when you have problem with the saturation, you know that or the lung, or the metabolism, or the hemodynamic, or the transporter, there is something wrong in the system. And let's see, what is our normal oxygen transport? The oxygen transport is the product of the cardiac output and the arterial content. Normally, we have more or less 1 liter, 100 milliliter of oxygen transport per minute. And when you arrive to the periphery, some of the oxygen is sucked, about 1/4 of 1/5 of the offer of oxygen, and the remaining is, of course, the venous saturation. So the venous saturation may be also seen as 1 minus the ratio between oxygen consumption and oxygen supply. Supply, VO2, consumption, VO2. And let's see, these are the determinants of SVO2. And you see, as an example, if we decrease percent of decrease of arterial saturation or cardiac output or hemoglobin or some increase in oxygen consumption, this is how the SVO2 change. And you can see that hemoglobin and cardiac output do have the same rate of relationship with SVO2. And the saturation of oxygen, of course, is like this. So this gives you an idea on how much the different components or determinants of the oxygen consumption play a role. So now we have, let's see, I have a patient in sepsis. This patient usually do have a central venous catheter. Nobody uses anymore the Schwangans, almost nobody. We still use. So we can surrogate the mixed venous saturation with a central venous saturation. But let's see, I may have SVO2, which is greater than normal, or SVO2, which is lower than normal. So we have to sit down and think, if I have a patient, maybe with 5 of lactates and 75 of SVO2, how to combine? Is the same patient as having 5 of lactate and having 55 SVO2? Or the pathophysiology behind is different? You know, high SVO2 means that inappropriate the ratio between oxygen consumption and oxygen supply is something wrong. I have less oxygen consumption than necessary, so the saturation goes up. And this may be for hypersynthetic circulation, may be peripheral shunt of mitochondrial dysfunction, which is impossible to discriminate with the instruments we have now. And we may have also some severe alkalosis which change the hemoglobin saturation curve. Then we may have lower SVO2. A lower SVO2 means or the cardiac output went down, or the oxygen consumption went up, or the hemoglobin went down, or the oxygenation went down, or we have acidosis. So you can see the picture between SVO2 higher and lower may refer to different, deeply different pathophysiological events. Now, look again to low SVO2. Low SVO2 means that there is some alarm on possible energy failure, so energetic crisis, and may or may not, but is an alarm, low SVO2. But when you have an energy failure, that means we are shifting toward the anaerobic metabolism. We have all this, which means that the problem is the energy. Low pH, high lactate, negative base excess, decreased strong ion difference, high VPCO2, all these are a sign of energy crisis. Now, this is a very interesting data because we grow up with an idea that we have when you have a glucose enter into the cells, the glucose is metabolized to pyruvate in exchange of oxygen. The pyruvate is transformed in lactate. Is that true? Because we have another possible view of the phenomenon. If we count the atoms which of the glucose, we have 6 carbon atoms, 6 oxygen atoms, and 12 protons, hydrogen. Now, if you count, this is exactly the amount that we have into lactate. And when we have this transformation, in this model, the natural end of the glucose is not a pyruvate, is a lactate. During this process, we produce 2 molecules per mole of glucose, 2 moles of ATP, which is immediately recycled to have again ATP. So this one plus this makes again ATP. Our cell has a deep disequilibrium between ATP and ADP because all our enzymes are to maintain are devoted to maintain some level of energy into the cells. So we are not in biochemical equilibrium. It's a sort of equilibrium at a higher level. If we leave the cells alone, all the ATP will be transformed to ADP, and that's it. End of the games. So this is the classical view. We have the cell membrane. We have in action of oxygen from glucose, the pyruvate. The pyruvate does not enter here, and we have transformation lactate, and lactate get out and goes to the blood to increase the lactate. Is that true? Well, we have other models. One which gained a lot of popularity in the last years, and is the lactate shuttle that I personally I prefer. Okay, which is that the glucose, even during aerobiosis, the lactate played a major role. In a normal cell, even in presence of oxygen, the lactate into the cell is about 20 times higher the concentration than pyruvate. And now try to look at this picture, because it's quite important, I think. Let's see, we have a glucose. This is a cytoplasm. We have a glucose, and the natural end of the glucose is lactate with the production of 2 ATP. Okay? 2 ATP become 2 ATP, phosphate and hydrogen, which are immediately reconverted to ATP. So from glucose to lactate, we don't gain and we don't lose any proton in the cytoplasm. Then the lactate enter in the intermembrane space of the mitochondria, and you have the lactate dehydrogenases. Okay? So the lactate has a 3 possible way. Goes to alanine and enter in the protein metabolism, or the excess of lactate through a transporter get out from the cells and enter in the plasma. And the third way is the metabolism through the lactate dehydrogenase. Because pyruvate, we have a translocation of the pyruvate, which become acetyl-CoA in presence of thiamine, which is a vitamin. The protons here enter, and both goes in an energy charged compounds, which is used to produce the ATP with the respiratory chain. If you look at this one, you see, okay, which are the reasons why the lactate is increased, with or without change in acidosis, is a key point. If I have an excess of glucose, I may have an excess of lactate. Excess of glucose, what can it be? Might be due to, as an example, adrenaline, all the catecholamine we use and so on. They have a deeper effect in the glucose and glucose metabolism. Or maybe I have a deficit of vitamin B1, the thiamine. Or I may have in the Krebs cycle, I have a lack of the final receptor, which is oxygen, or may have a problem with all the enzymes that are present in the mitochondrial chain, which produce energy at the end. So you see there are several mechanisms through which I have an increased lactate. I have an increased lactate when the possibility of metabolism of lactate are in a given cells are overcome. Oxygen is one, lack of oxygen in one of the possibility. But as an example, if I have a problem of oxygen consumption, of oxygen utilization, because my respiratory chain has some problem with the oxygen radicals and so on, so some enzyme is not working, lactate goes up. And so you may see that lactate goes up when the oxygen transport is lacking, the classical view, but may goes up also in perfect presence of oxygen when the oxygen is not utilized. And you see here the link, and then there's need to consider together the saturation of venous saturation in one side and the lactate in the other side. So, lactate oxidation capacity is increased. Sorry for this slide. So, what's happening in sepsis? And look at the lactate. In lactate, you see that is known since decades that I have one sort of linear, almost linear relationship between mortality and outcome and the level of lactate. So lactate, there is no doubt, when lactate goes up, we have body has some problem, and some severe problem. Okay? 2, 4, 4 to 6, 6 for 8, greater than 8. Then, if you look at the time course, I think it's a common experience for everybody to see that after, with days, maybe whatever you start with the lactate, high lactate, lower lactate, if the problem is not solved, the lactate tends to reach a sort of equilibrium. Why? Why I have some patients which stay, as an example, are 4 lactate for days. You have to remember that our tissue had a tremendous capability of consuming and utilizing lactate. So if I have a part of the body, or part of the tissue, or part of the metabolic unit, which are unable to eat lactate, the other one may increase their capability. So we reach a new equilibrium, because this has been shown in dialysis that the amount of the metabolism of lactate is depending also by the offer, by the supply of lactate you give to lactate consuming organs. And what's about the oxygen saturation? These are, if I recall right, about 1,700 patients with sepsis. Now, the usual normal values of sepsis is around here, about 70, 75. And you see that only about 35% of the patients have a oxygen saturation lower than 60. That means the transport to the periphery is limited to 35 patients. What about the rest of the patients? Some have normal SVO2, and some has very high SVO2. So very simple, you can consider this one, transport, this one, utilization. So, look at the mortality. Mortality is very high. These are six types of SVO2. That means Here the SVO2 was between 24, 62, from 63 to 69, 70, 73, 74, 81, 82, up to 98. I don't know if 98 wasn't an error, but you have a significant U-shaped curve. So the worst outcome is when SVO2 is too low or when SVO2 is too high. And look at the lactate. If I put the lactate versus the sextile, lactate is higher at very low, and it's again higher at very high SVO2. But always the lactate is above the level that we set for sepsis. Now the guidelines say, okay, give fluid here and give fluid here. But here the problem is not the transport. The problem is utilization. And I don't know if it's a great idea to give a lot of fluid in this condition. Now, if we look now at the SVO2 sextile, okay, you can see that the SOFA is going like this. The SAPS is going like this. The creatinine is going like this. The need for renal replacement therapy is like this. It is maximum at the two ends of the spectrum. So this is the mortality, higher here and higher here. And so let's look at the transport deficit. This is a model. Let's see. I have decreased 3 liters. I have decreased oxygen oxygen supply, and I have 1 liter goes in these units, 1 liter here and 1 liter here. You have the glucose. The glucose becomes lactate, and this goes in the mitochondria. The lactate goes in the mitochondria, is consumed, but I have too little glucose and too little oxygen, and lactate goes up in all the 3 units, and SVO2 goes down. But that's another question, another kind of situation in which I have the normal cardiac output, and I have part that goes here. Here is pretty normal. I have the glucose. The glucose enter in the mitochondria as a lactate. Oxygen is enough. The SVO2 is okay. This is a sort of the reverse relay model. This is an ideal SVO2 tissue. Here I have the ideal SVO2 tissue, but look here. I come here, the glucose enter, it becomes lactate through the anaerobic metabolism. I do not have oxygen. Lactate goes up, and I have this shunt. This, the peripheral shunt, or the lack of utilization are indistinguishable in this kind of issue. And now let's say, look here, I have the sextile of base excess. And you see that even with base excess positive, the lactate may be higher than normal. And look here, with the lactate around 3, 2.5, 2.8, in this condition, the pH may be as high as 7.5. What's happened? Because if I use lactate, according, or lactic acid, according whatever model you want to use for the acid-base equilibrium, you have the you have to have acidosis. Okay? But here we do not have acidosis in a lot of these patients. So why acidosis is associated? I suggest you to take the base excess and to introduce this concept, the alactic base excess. Let's see. I have a base excess -5. Lactate is 3. If I make the sum -5 plus 3, I have the alactic base excess. That means is the amount of decrease of base excess which is not justified by the lactate. If it's not justified by lactate, means that other acids are present. Okay? Here is 0, and here base excess is +5. Okay? This means or alkalosis from other question, or volume contraction, or use of diuretics. So at the bedside, if you have lactate, so you have immediately, if lactate, alactic base excess is positive or negative. And so, what's happened? Here, there is no question, the lactic base excess in sepsis beautifully reflect the renal function. That means the base excess is, lactic base excess is very high when the creatinine is very high. That means the kidney doesn't work. If the kidney doesn't work, it cannot compensate for the acidosis induced by the lactate. So, to have acidosis, you need that the kidney cannot compensate for the lactate production. And so this is the last slide. And you see, you have this deficit, VO2 and DO2 is low. This is a transport deficit, okay? And you have the SvCO2, which is low, but you have the lactate, which increase. Here is the other part of the spectrum. Lactate always increase. This is why lactate is so powerful, because in whatever condition, lactate goes up. But what tell you what is going on is a saturation. High here and low here. Then lactate goes into the blood. Goes into the blood, the strong ion difference decreases, the pH goes down. Now, if you have a normal renal function, the lactate increases on seed to correct the decrease of this one. And the pH goes up. If the renal function doesn't work, you have reduced, you have the pH. So, to summarize, if you have a lactic base excess, tell you kidney function and acidosis. Lactate goes up in whatever situation you have, SvO2 goes up in when the utilization is low, or goes down when the transport is low. And this may help you to orient a little bit the sepsis treatment. I thank you for the attention.